Boa noite a todos, sejam bem-vindos ao webinar Gadali Prostland, falando sobre o Schelin, o CoreFlow. Conosco hoje estamos o Svecker, nosso parceiro de negócios no exterior, o Gohan, Dr. Siena, Dr. André Cavalcante e o Dr. Schelin, conversando com a gente sobre técnicas cirúrgicas usando esses dois dispositivos. Svecker, com você.
Good evening, everybody. I wish you a very warm welcome. It's an honor and a pleasure to welcome you on behalf of Prostalund and Gadali Medical. The theme tonight is benign prostate enlargement, how to enhance it, how to increase patient safety, patient comfort, around the themes of CoreTherm, Schelin Catheter, and CoreFlow. So it's also an honor to introduce the presenters and the moderator, starting with the moderator, Dr. André Cavalcanti, a consultant urologist who is a reference in introduction of new techniques in Brazil and is based in Rio de Janeiro. Our colleague Göran Dybner, who is the director of sales and marketing at Prostalund, so he's responsible for how we present, how we introduce this technology around the world. He's based in Sweden, he's Swedish. Dr. Gianpaolo Siena is a consultant urologist in another beautiful city, Florence in Italy, also very much associated with the use of minimally invasive techniques such as the Rezum, and he's going to share his personal experience from the Schelin catheter. And Dr. Sonny Schelin, also a consultant urologist based in another lovely town called Kalmar in Sweden. He will talk mainly about the CoreFlow, but also share his experience of the Schelin catheter in TURP procedures. And I should add also that Dr. Schelin is the inventor of all these technologies that we're talking about. So without any further ado, I pass the word to Dr. André to open up the session and introduce and moderate the different presentations.
Bom, boa noite a todos. É um prazer estar aqui em mais esse evento, discutindo novas tecnologias no tratamento da hiperplasia prostática benigna. A gente tem observado nos últimos anos o surgimento de novas tecnologias. Então, depois de anos com o uso do tratamento medicamentoso e com poucas tecnologias disponíveis, com muito receio dos nossos pacientes a sequelas relacionadas ao tratamento da hiperplasia prostática benigna, a gente vem renascer o interesse do urologista pelos tratamentos cirúrgicos para hiperplasia prostática benigna. Começaram com a substituição da terapia da energia monopolar para energia bipolar, posteriormente a introdução dos lasers como green light, mais recentemente o crescimento constante da utilização do rolê no nosso país, e ainda mais recentemente as terapias minimamente invasivas, como o Urolift e o iTind, que já são disponíveis, e o Rezum, que é uma nova tecnologia que está chegando, e novas tecnologias que também serão discutidas essa noite. Bom, a gente vai começar com a apresentação do Goran, representando a empresa, e posteriormente Dr. Siena e Dr. Schelin vão falar em sequência, e ao final da apresentação a gente vai abrir para uma sequência de perguntas e discussão. Todos aqueles que tenham interesse em fazer algum questionamento, alguma pergunta, serão todos muito bem-vindos e podem fazer isso através do chat. Goran, por favor, faça a sua apresentação.
Göran, time to go.
Good evening. My name is Göran Dybner, and I'm the Marketing and Sales Director for the company of Prostalund. We are a Swedish company that has been around since the mid-90s, where the main focus has been the core-therm treatment, which is an heat ablation treatment with using the microwave technology, which then has been further developed into the core-therm concept. And we are a publicly traded company at the Stockholm stock market in Sweden. The main focus for tonight will be what you see on the left, which is the Schelin catheter, and on the right, which is the CoreFlow soft stent. But I think it may be a good idea for you to have an idea about where these two devices come from and why they have been developed. So all in all, what you see here is our product portfolio, which is then the core-therm concept, which consists of the Schelin catheter on the left, the core-therm machine and the core-therm catheter, and at the end, the CoreFlow soft stent. So the Schelin catheter was invented in order to provide local anesthetics into the prostate before performing the core-therm treatment in the middle. And when performing a core-therm treatment, the prostate will swollen, and you need some kind of relief after the treatment. So that's why the idea of a soft stent that could be used instead of an indwelling catheter after the procedure. So that is the ideas and the developments that has been made in order to enhance the core-therm concept. What we have found out during the last year is that we can use the Schelin catheter for quite a lot of other areas when it comes to prostate treatments, as well as we have the CoreFlow soft stent, which also has other areas of use. And you will hear more about these from Dr. Siena and Dr. Schelin later on tonight. Core-therm concept as such is a therapy that has been developed for more than 25 years. And there are evidence that we can deliver the same symptom relief as a surgery, the TURP. But this can be performed in a polyclinical setting, in local anesthesia, and the patient can go home directly after the treatment. And of course, since this is a minimally invasive therapy, there is less risk for serious adverse events. And this is a method that is approved not only in Europe, but also in US and in China, but not yet in Brazil. And as I said, this is a development from the generic transurethral microwave therapy, the TUMT. It's based on high energy. The antenna is approved, so it gives you a defined, sharp, and reproducible heat pattern. And what we do as well is that we measure the temperatures within the prostate during the treatment, and thereby it gives us the possibility to calculate the cell in real time as well. And this is a very important development in this therapy. With the Schelin catheter that you will hear more about later on, we can provide a pain-free treatment with the help of providing local anesthetics together with adrenaline into the prostate. And the adrenaline as such makes that the TUMT treatment with core-therm doesn't take longer than 14 minutes maximum, on average some 8 to 9 minutes. We also measure the energy dosage that is provided as well, and we use that to have a secondary endpoint in the treatment. And with the CoreFlow soft stent, which you will hear more about later as well, we can replace a catheter after the treatment, and which of course is much more comfortable for the patient, and it reduces the risks for urinary tract infections. This is a method that is increasingly used in the Nordic countries, mainly in Sweden, where it stands for approximately 20% of all the BPH procedures that is performed in the country. So historically, it has been mainly for the old and fragile patients that they couldn't provide surgery on, but now with a lack of hospital beds, the anesthesiologists, the nurses, etc., it has become much more popular within the country, and also the fact that patients actually are asking for this kind of minimally invasive treatments. This year, we have a new platform that is MDR approved, which is the new regulations that we have in Europe. So this is a quality stamp that is really impressive, and the whole look and design of the platform is much more modern, and there are built in quite a lot of new features in to improve safety and also improve the user friendliness for the operators or the surgeons. CoreTherm, there is a lot of documentation, a lot of studies that have been performed. There are 3 doctoral theses on CoreTherm. I will not go into details on all of the development, but I would like to highlight some of the main studies that has been performed. And as I mentioned, there is evidence that CoreTherm delivers the same kind of symptom relief and results that you expect from a TURP. So no statistically significant differences was found in this prospective randomized multi-center study that was conducted in the United States and Scandinavia some 15 years ago. But as you can see at the bottom, the safety is of course favorable with CoreTherm compared to TURP, since it's a minimally invasive therapy. Looking at the IPSS scores, it's very similar over the 5-year period as well. And this is what it could look like when you look at transrectal ultrasound some 3 months after a CoreTherm treatment. So you will see a cavity that is very similar to that you see after a TURP. What is important is that with CoreTherm you can also treat the large glands. I mean, when you have patients that have a prostate that is bigger than 80 or maybe 100 cc, there are not that many options for you to choose between. What Fredrik Stenmark, who presented and defended his thesis in Göteborg in Sweden 2 years ago, he presented this study where he retrospectively has looked at 570 men that has been treated with CoreTherm. All of them had prostate sizes of more than 80 cc. And as you can see, the long-term results, the median follow-up was more than 10 years, and still only a little bit more than 10% needed to be retreated with surgery. And this is the publication that was in Scandinavian Journal as late as in August last year that it was published. The last study that I will look at take up here is that this was presented. It's not published yet, but it seems from the Swedish registers that the research group that has looked at it, it seems like the CoreTherm reduce the risk of developing prostate cancer in the follow-up period when you compare it to the TURP. And also the prostate cancer specific mortality was lower for the patients that was treated with CoreFlow. Maybe that the heat treatment actually also kills the prostate cancer cells. So CoreFlow concept of today, it's a pain-free 5 to 15 minutes, minimally invasive outpatient office procedure that can replace surgery in very many cases. And it's a treatment that you can use for old and fragile high-risk patients. It's an alternative for patients that already are having the anticoagulant medication, and you can treat patients no matter of the prostate size, since there is no upper limit. So that was a brief description of the CoreFlow concept. But now you will hear more about the two catheters on each side, the Schelin catheter and the CoreFlow soft stent, which then can be used in other situations as well. And they are approved in Brazil today. Thank you.
Thank you. Can you move to Dr. Siena? And then at the end, we can close with all the questions and discussion.
Good evening, everybody, and thank you for the kind invitation. I will talk about the Schelin catheter. The Schelin catheter is a device that allows sterile intraprostatic injection of local anesthesia or other drugs. It can be used for local anesthesia before treatments like water vapor therapy or prostatic lift, urethral lift, or in case of major surgery, along with mild sedation like green laser, whole-up, and TURP. And in this case, it's been used in sporadic cases. There's also a future research areas like diagnosis or treating prostatitis, because we can deliver, along with the anesthetics, we can deliver also other drugs. This is how the Schelin catheter is made. It's a 3-port catheter with a drainage outlet, an injection wheel port, and the balloon inflation valve. At the tip of the top, at 12 o'clock position, we have an arrow indicating the 12 o'clock position. And the catheter is shaped with a curved tip, a bit like a T-man catheter. We have the standard balloon and 5 centimeters caudally to the balloon. We have the needle that comes out with a 30 degrees angle, and it comes out for 4.5 centimeters. The needle is a retractile needle and has a gray marking that indicates we can see this marking from the outside of the catheter in order to see how much of the catheter has been inserted into the prostate. So how to perform the local anesthesia? Of course, we have to follow the anatomical rules. We know that neurovascular bundles run mainly at the posterolateral aspect of the prostate. About 60 to 70% of the nervous fibers run at this level, and 20 to 30% of the nervous fibers run at the anterolateral aspects of the prostate. So the majority of the anesthesia should be delivered at the posterolateral aspect, and according to this protocol, we can inject 7 milliliters at 4 o'clock, 8 milliliters, 7 milliliters at 8 o'clock, These are delivered at the deepest part, the majority, 3 milliliters, then 2 milliliters, we can withdraw then the catheter and inject another 2 milliliters and then 2 milliliters again. So it's 3, 2, 2. And at the anterolateral aspect of the prostate, at 10 and 1 o'clock position, we can deliver in one shot 3 milliliters. We can see better the procedure here. How it's performed is very simple. And this is the catheter. So we insert the catheter as a standard catheter, inflate the balloon in order to void the bladder. So we fill the balloon port. We can void the bladder and stretch the catheter against the bladder neck. So we know that the catheter now, the balloon is placed at the level of the bladder neck. We can then withdraw. We can then withdraw the urine, drain the urine, and we can inject 20 milliliters of mepivacaine or lidocaine at 1%. Using the arrow, as you can see, we know that we are injecting now the anesthesia at the level of the left lobe, the posterolateral aspect. We inject the first 3 and 2 and then 2 milliliters again on the left side, as you can see in the animation. Then we can turn the catheter, stretch it again against the bladder neck, and inject the other 7 milliliters of anesthesia. Again, before 3, then we can withdraw the catheter, 2 milliliters, and then another 2 milliliters. Then we can turn the catheter again and inject the 3 milliliters anterolaterally, both sides. As you can see also in the animation, there's 3 milliliters on one side. We would then turn the catheter again, stretch it against the bladder neck. It's important to do this movement so we're sure that the catheter is at the right place, and then inject the last 3 milliliters. Once we've done the we performed the local anesthesia, we can remove the catheter, and I'll show you how we will perform this is a resume procedure. So we inject water vapor. This is how it appears inside the prostate lumen. As you can see, there's no real bleeding. This patient is completely awake, and we are injecting a water vapor. Water vapor is at 104 Celsius degrees, so it's very hot, but there's no pain felt by the patient. So there's a wide experience since 2005, as described before by Göran. Over 13,000 core therm cases have been performed in the Nordic region, where the Schelin catheter is being used and used to administer both lidocaine and adrenaline in order to obtain a substantial painless treatment and reduce blood flow during treatment in order to shorten the procedure. Since 2022, the Schelin catheter has been introduced across Europe to administer lidocaine before water vapor treatment, prostatic lift without any further anesthesia, and in case of definitive surgery with light sedation, in case of green laser whole open QRP. These are the published papers. Schelin 2002, they reported less analgesic and use and reduced treatment time for TUMD. Schelin in 2004 and 2009 reported reduced prostate bleeding and reduced perioperative bleeding after QRP. Knudsen in 2009 reported a reduced need for intravenous analgesic and reduced treatment time for TUMD. And Stenmark in 2021 reported a larger resection weights in case of QRP. And we reported in 2023 the first paper on use of Schelin catheter with before resume treatment. This is the paper has been published on prostate cancer and prostatic disease. We know the efficacy and safeness of resume is being widely described in the literature. So we sought to find and evaluate advantages and feasibility of a intraprostatic anesthesia before the treatment. So we enrolled 20 men who underwent resume treatment, and they were treated before with local anesthesia using the Schelin catheter. Prior to the procedure, patients were asked to rate their pain on a numeric rating scale from 0 to 10. 10 is worst pain. These are the data. 20 patients, 60 years of age, median prostate size of 75 milliliters. And the median treatment time was 3 minutes for local anesthesia and 6 minutes for resume treatment. All patients were discharged 4 to 6 hours after the procedures. These are the results. As you can see, the median pain is very low, and the highest is at the moment in the moment of the water vapor injection, of course. In one case, we had a patient reporting 6 on this numeric rating scale of pain. In this case, the anesthesia probably faded away because we had we had an issue with the resume instrument, and the procedure itself took longer time. So we did the anesthesia, then the instrument had some issue. We had to wait, and probably the anesthesia faded away. So in conclusion, the findings we had on this minimally invasive treatment was that no perioperative anesthesiologic and procedure-related complications were reported, catheterization time 7 days, and no cases of acute urinary retention or urinary tract infection at 30 days postoperatively were recorded. And interestingly, we observed that patients after this treatment reported a minimal discomfort due to the treatment and due to the catheter, the indwelling catheter. This is probably due to the preemptive effect, and it's a possible field of further investigation. But this has been an interesting report because usually patients who have this treatment report discomfort or mild to moderate pain due to the catheter and the treatment. And in this case, it was lower than usual. So some more feedbacks can be done also from my colleagues, Italian colleagues from Rome and Modena. They done the first case of the green laser, a green laser procedure with Schelin catheter anesthesia and HOLEP. Thank you for your attention.
Dr. Schelin?
Yeah.
Please.
Yeah, thank you for inviting me to present my inventions. I'm very happy. And now I'm going to talk, as there were some interest about the TURP surgery and a way to block intraprostatic blood flow and reduce the bleeding and the blood loss during TURP surgery. There are not much science about it. I have used it regularly myself during 13 years from 2004 and to the end of 2017. And I did several hundred cases with TURP and adrenaline injections just before. And the technique I used, I injected the right side of the prostate. I gave 10 milliliters of mepivacaine adrenaline 10 to 11 o'clock and 8 o'clock. And then I took the Schelin catheter out, and I introduced the resectoscope, and I performed a right-sided TURP operation, mostly according to a modified Nesbitt technique, or I even used the Mauermeyer technique as well. And my colleagues know how to do that, of course. And then after the right-sided surgery, I took the resectoscope out and I reintroduced the Schelin catheter. I filled up the balloon up to 40-50 milliliters, not having it good down in the resection cavity. And then I injected 1 to 2 o'clock and 4 o'clock, and then I came back with a resectoscope and I performed a left-sided operation. And this technique was to avoid washout of the adrenaline effect if I had injected both sides at first. So this is a way to do the surgery without bleeding. In my experience, you can see here that I performed a pilot study that was published 2009, and I had 11 cases with adrenaline compared with 30 cases in a control group. And it was just to have some idea about how it worked. And the blood loss was only 1/3 after using adrenaline, and the bleeding milliliter per resected gram was only 1/3, and operating time was reduced. But in my experience, during several hundred cases, I could never think to do a TURP without adrenaline when you have been used to it, because you don't need to coagulate during resection. You can just, like, it's like cutting cheese on the breakfast table the first minutes, when you can go very quick and go down to the capsule, and after some 10 minutes the bleeders will come back slowly and you can recognize them and coagulate them. And I think it's much better. The visibility is much better. If I have a younger doctor that I will educate, he can do more surgery before I have to take over, because the visibility is much better. And I think the resection will Now I will present the CoreFlow soft stent. It's like an ordinary Foley Nelaton catheter and can be used like that, as you can see. The only thing is that the lower adapter to inject water to the balloon is outside the outer part of the catheter. Next. So you can see the blue tiny thread in the outside of the catheter. If you release that, you can disconnect the outer catheter part from the stent part, and you can see below the stent activated, and the external sphincter can close below the stent and above the coil, you can see. Next. So it's a temporary stent, and it's allowed to be used for 29 days. Next. And the areas of use are several. You can use it in the situation with an acute retention and a chronic urinary retention to relieve the obstruction immediately, and can achieve a spontaneous normal micturition. And you can use it after active treatments to replace an indwelling catheter to reduce discomfort for the patient. And you can use it as a diagnostic tool. For example, patients with neurologic diseases, Parkinson, stroke history, patients with spinal trauma, pelvic surgery, where you can suspect some neurogenic dysfunction. You can do a stent test, and I have done that for many years now in almost every patient stuck to a catheter with chronic retention. What you do, you put the catheter stent inside, you fill up the bladder slowly until the patient feel an evident urge to micturate. And then you disconnect and activate the stent, and the patient is told to move about in the examine room for 5-10 minutes with a full bladder activated stent. And if he can stay continent during that time with a full bladder and relying only on the external sphincter, you can go for surgery or an active treatment without risking incontinence. Another thing you can do with these patients, you can use the stent to check out the neuromuscular function. If the patient can activate and micturate with the stent in place, you can go for surgery or an active treatment, because then you know that all the reflexes, the activation of the detrusor and relaxation of the external sphincter coordinated is in function. Next, please. There are 3 different lengths of this stent, and in my experience, if the prostate length is about more than 35 millimeters but less than 45, I used a 30 millimeter stent. Between 45 and 55 millimeter length of the prostate, I used a 40 millimeter stent. And if the prostate length is more than 55 millimeters, I used the 50 millimeter stent. Next. So it's important that you check the axial length of the prostate by truss before you decide what stent to choose. Next. So you put the catheter in and fill up the balloon, and you anchor the balloon to the bladder neck as you do with any catheter. Next, please. And when you have activated the stent and removed the outer catheter part, you can see the stent is going through the whole length of the prostate, and the opening is just above the external sphincter, which closes between the end of the stent and the coil going to the balloon. Next. And if you have the neuromuscular function intact, you can immediately void with a good stream. Next. And here comes an animation film to show how it works. I think it's important to inject more than 20 milliliters of anesthetic jelly to have a pain-free insertion. So if you release the blue thread outside, which keep the two parts together, it's very easy to retract the outer catheter part. And it has been used after the resumed treatments in a few countries as well. And the patients are voiding with a very good stream immediately after the water vapor therapy. You cut this lower adapter away because it's not so nice to have in the pants. And now the patient can initiate and void empty his bladder in a normal way because the obstruction is relieved. If you pull the blue thread, as you can see to the left, you can move the stent downwards to open the external sphincter. So it's an antegrade self-catheterization. As long as you maintain the pull of the blue thread outside, the sphincter will be open and the urine can pour out easily and passively. So it's just cutting about the knots, and the balloon will empty by itself, and you can take it out easily. Yeah, here you can see the catheter functioning as a catheter fully inserted, and the balloon is filled up. Next. And then if you remove the external part, you can see the sphincter will close below the stent and above the coil, and the blue thread is hanging out. And next. Then if the patient is able to void, have a normal function and control, he can void himself by help of the stent. But if he has a weak bladder or some neurologic disease, he can do antegrade self-catheterization. To the right part here, you can see the balloon is deformed and it's going down and deforming also the bladder neck. And you can, by pulling and maintaining the stretch of the thread, you can have the sphincter totally open. And so it's antegrade self-catheterization. Next. There were a study performed in Russia 2009. Krikobodorov, a doctor I met when I was talking about this in Moscow, and he performed a small study. Next, please. He had 19 patients with neurogenic diseases, and 8 of them had a prostate enlargement, and 11 had no adenoma. And he performed this stent test. None of the 11 patients without BPH could micturate by help of the stent, but 4 of the 8 patients with a prostate enlargement could micturate by help of the stent, and they had a TURP with good outcome afterwards. So this the stent test can help you to decide if it's meaningful to do an active treatment or not. Next. the conclusion was that the stent test is performed very easily, and you can use it with a double purpose to check the capacity and the competence of the external sphincter if you have a neurogenic disease, and you can check that the neuromuscular control of the blood and the sphincter functions and pace together will be functioning before you decide to do an active treatment. This urodynamic easy stent test could be performed in the office by the doctor himself just in a few minutes. Very easy. I did it many times. And a long time ago, I performed a retrospective study about the CoreFlow used after the core-term treatment. I had 51 cases, consecutive cases, and I put the stent inside instead of an indwelling catheter the 3 to 4 weeks after active treatment. And I did it like this. I flushed the catheter until the return was clear from blood, and usually I waited waited out the bleeding time and coagulation time, so I didn't activate the stent before 15 minutes had passed. And then I filled up the bladder when with saline, and I separated the part, and the patient had to do a void test, and I could check continence with a full bladder first, and then the patient was asked to micture it, and if it worked out that he was continent and could void himself spontaneously, he could leave the clinic with the stent in place instead of an indwelling catheter. And next please. So in the outcome was I had to take it out in 1 out of the 51 cases because of premature clotting, some kind of occlusion, and there was not a single clinical symptomatic UTI, and there was only 1 patient having a positive urine culture with checking up after stent extraction. So the conclusion is that the device can be used instead of an indwelling catheter after active treatment. And in my experience, the patients were very happy and had very little discomfort compared to the catheter, at least the 2-3 first days after introduction. And the UTI risk was very low, and I think that could be because the patient is flushing his urethra inside out repeatedly in a normal way, and that will prevent the UTI situation. Next, please. So in summary, you can use the stent in acute and chronic retention. You can use it after active treatments, core-term, resume, and so on. And you can have it as a stent test to check continence and check the micturition neuromuscular function before you decide to do an active treatment. And in some cases where the patient are bound to have self-catheterization, he can use the stent instead of clean intermittent self-catheterization by having pulling the thread every time he needs to empty his bladder. But many patients have tried it and it works, but many prefer an indwelling permanent catheter because you must be quite young and mentally functional and physically functional to cope with a stent self-catheterization, in my experience. Next. Thank you.
So thank you for excellent presentations, very complete. But we still have some questions. First, a little bit about the core term, because urologists in Brazil are very excited about these new techniques. One is some, maybe for Goran to the company, some question about the cost when you're comparing in Europe, at least, other techniques, especially the resume with the core term. Can you talk a little bit about the cost, comparing, not the absolute cost, but comparing with the other techniques? And if you can expect to have this technology in Brazil in the future?
The cost is very similar to resume, actually a little bit cheaper on a European level. So I would say that the treatment costs around 1,400 to 1,500 euros in total in the material from us. When it comes to registration in Brazil, that's what we are aiming for, but I assume that it will take some time before we are getting there. And I have to pass that one to Gadali.
If I, Dr. André, if I could just say that the cost of therapy, cost of treatment is always very different in Brazil to Europe, simply because of import taxes, different sort of state taxes and all of that. But of course, the comparison was given. And of course, what we will see is that I think within maybe this year, we will be very busy in Europe to spread the core term. And I also think that the ANVISA registration will indeed take some time. And it also depends from key opinion leaders as yourself. If you see a role, if you're convinced, if you look at the data, and if you think that we should be in Brazil, if there is enough patients, if there is a real interest, of course, I'm sure Göran and everybody else will do our very best to be available and to serve the community in Brazil.
Great. And to Dr. Schelin, Dr. Siena, comparing again resume with the core term, but on the clinical aspect, how is the postoperative symptoms between each procedure regarding the patient's symptoms, time of catheterization? How can you compare both and also efficacy of both minimal invasive treatments? Dr. Siena, Dr. Schelin, can you talk a little bit?
I only have experience from the core term, not from the resume. So I can't compare, but I'm the inventor of the core term concept. All of the developments coming along, and now it's functioning and stable and reliable, easy, pain-free outpatient procedure. Patients can drive the car home directly after treatment because they have no sedatives, no painkiller, strong painkillers. They can leave immediately. And if you are old and need a catheter or are bound to a catheter before treatment, some extra weeks with a catheter doesn't mind that patient very much. But of course, a younger patient able to spontaneous micturition before treatment could, we regularly put an indwelling catheter in for 3 to 4 weeks in after core term. But many patients have nocturia 3, 4, 5 times, and suddenly they can sleep the whole night with the catheter. So in many cases, it's not so bad for the patient. If you explain the situation and you explain that the bladder need to have the opportunity to find its function and by help of the catheter, and that the outcome will be very good and come quickly afterwards when you take the catheter out. And in some cases, we can put the CoreFlow stent instead, and then the patient has very little discomfort in the post-treatment period. But I think what I would like to stress is that we can do the really big prostates, because open enucleation surgery is expensive. It's a long waiting time to have that. It's not so it's not so safe either, and compared, it's much cheaper to do a cord-tongue in a large prostate than to do in hospital open operation or robot surgery or whatever what you like to do.
Dr. Sienna, can you add some comments regarding these methods?
Yes, I think the all these minimally invasive treatments and outpatient treatments are here to stay since 2007, 2008. If we look at the number of TURPs compared to the minimally invasive surgical treatments called MIST, number of TURP is going down and the number of MIST procedures is going up. So these new techniques are here to stay. Probably in the numbers, we have to look at many things that include the cost for the procedure, as Goran stated before. Cost is an important parameter for each healthcare system, for clinicians in general. Skill set, so what is available, what we have available in our centers, and if we have to compare similar procedures in a way. There's no comparative studies at the moment among MISTs. There hasn't been any randomized clinical trials that is reliable. In case of Resume, there's the pilot study by McVary is a randomized clinical trial between Resume and sham treatment. The sham treatment was cystoscopy, but the sham group turned into the treatment arm after 3 months. So it is not a real RCT, if we want to say. But if we look at the data, the results are pretty similar, because the core term has a longer history compared to Resume, but they provide a similar treatment. The cost is different, and as I hear, the core term is cheaper for the healthcare. The question was about side effects, I guess. Is that correct? There was also a question about side effects, or
yes,
and efficacy. So the efficacy and side effects are normally mild to moderate, and normally they're irritative symptoms, the cystitis-like symptoms. And in this case, we have about, in case of Resume, we have about 30% of the patients who experience cystitis after the procedure. These side effects tend to go away within the first 3 to 4 weeks. What we are trying to do now, using the Schelin catheter, is to inject cortisone, high dosage cortisone, Kenacort or dexamethasone before the treatment, and make a cocktail of mepivacaine or lidocaine plus cortisone in order to reduce these side effects that are due to the irritation of the glands. There's an interesting paper about the cost. It's been published by Ulkaer, and they basically evaluated the IPSS. If you want, I can show you a slide. I can share maybe I have a slide here just to give you an idea of the. See if we can. This one. If you can see here on the image at the bottom of the cost, in this paper they've compared several techniques according to the IPSS and the cost of the procedure. So the best procedure basically has to be on the right and at the bottom. So if it's at the bottom, it's cheaper. The more on the right is, the better, because it's more effective. As we can see, combo treatment with drugs or generic are basically expensive, and they also have a average IPSS at 2 years that is less performing compared to any active treatment. So when we talk about minimally invasive treatment like CoreTherm or Resume, we have to compare them with drugs. And if we see the cost of the drugs, especially if branded, the branded drugs, if we compare this to minimally invasive treatment, there's no comparison after all, because it's basically cheaper and it is more effective in terms of IPSS resolution. So the share of patient that we have to aim at is patients that are under therapy, basically.
So we have some questions from some Brazilian urologists regarding the use of the Schelin catheter to prostate biopsies. Can you make some comments?
I think there are very little experience from that. Theoretically, I think if you have a suspect cancer MRI picture with period 3, 4, 5, and you want to aim with a fusion technique with ultrasound aim at the MRI picture to find the suspect part of the prostate. The injection of a lot of fluid inside the prostate with a local anesthesia could perhaps make it difficult to see the suspect part of the prostate. But if you want to do randomized biopsy, 10 to 12 from side to side, I think it would be perfect to do this anesthesia. That could help, I think.
Dr. Schelin, how is the best way to check the length of the CoreFlow stents? Is transrectal ultrasounds?
Yes.
But can you use other methods as MRI or?
Yes, if I do that because in some cases, but it's not so reliable with the MRI picture. That if you do the transrectal ultrasound and look at the sagittal view and measure the length of the axial length of the prostate, that would be the best way to do it, I think. If in many cases you can't get the length from the MRI answer, you have to calculate it backwards to estimate because the width and the length is almost the same, and the height of the prostate is some 60% of the way. So you can do some kind of retrograde calculation and estimate. And if you have a very large prostate, I think it's no problem. Then you must choose the 50 millimeter stent. But if you have a small prostate, I think MRI won't be good enough to. I think the truss measurement will be the way to do it, I think.
So I think that is the last question, because you are going to 8 o'clock, 8 p.m. here is in probably are more than midnight to Europe. So the last question, when you are using for the self-catheterization, you measure it in the same way for the obstruction. There is some trick to get the measure to use for the self-catheterization in the neurogenic patient, or it's the same basically?
Oh, it's the same.
Okay, so thank you everyone. Any comments from the company or from the colleagues? Any questions? Then we can finish our meeting.
Yes, Dr. Andrea, thank you so much for moderating the session. I think this was highly communicative, very, very, very good give and take, really excellent exchange of communication. And I really see that there is a room short-term both for the CoreFlow as well as the Schelin catheter to be evaluated, and over the longer term, the CoreSerm. So thank you so much to the presenters, to Dr. Andrea for excellent moderation, and of course for the audience for your interest and kind attention. Áurea, algumas palavras em português para encerrar o webinar?
Doutor André, muito obrigado pelo trabalho, obrigado por mediar nossa conversa, nosso encontro, que foi, assim, super prazeroso. Foi bem esclarecedor, teve dúvidas até, assim, que o senhor explanou de uma forma bem cordial e direta. Sabemos que as técnicas cirúrgicas e processos aqui no Brasil funcionam um pouco diferente do que na Europa. O material, o CarTerm, ele está sendo negociado, sim, com o pessoal da Prochland. Infelizmente, nós sofremos com a burocracia da Anvisa e da Receita, né? O senhor sabe como que funciona aqui. O processo de liberação do registro é em torno de 3 anos, porque conduz um certo tipo de energia elétrica, então demora um pouco esse processo, mas já está em negociação. Os demais produtos, eles hoje já se encontram com registro Anvisa e disponível no mercado, inclusive para testes do material. O pessoal da Prochland vai estar com a gente aqui na Jornada Paulista na próxima semana. Quem vai estar com a gente vai ser o Svecker e o Goran. E nós já temos alguns procedimentos agendados para aí confirmar na prática o que o material se propõe e se ele entrega realmente. O foco desses 2 produtos é a qualidade do paciente com hiperplasia benigna prostática, doutor. Agradeço muito pela sua atenção, pelo trabalho que a gente vai iniciar, e a gente vai se falar muitas vezes. Svecker, sempre é um prazer enorme falar contigo, meu amigo. Agradeço muito mesmo, Dr. Schelin, ao Goran e ao Dr. Siena pelo tempo. É importante lembrar, né, gente, fuso horário, vocês estão aí, já acredito que é mais que 1 da manhã, e estão fortes aqui com a gente nesse evento. Gratidão realmente, muito obrigada.
Boa noite a todos, até logo.
Até.